Did
Looks
that
good.
work?
It does. Yeah.
Brilliant. Thank you, Sabine, for the intro, and hello, everybody, and thank you for having me present on digital health equity. I'm just going to sort out my screen. Okay. So, yeah, I'll start off by telling you all a little bit about me. I'm the founder of Equity Health. We're a consulting company and we operate at the intersection of digital health and equity and support organizations, amongst other things, with digital transformation. So my background is working probably for about 25 years now across the health sector, both the NHS and commercial organisations, doing things like service improvement, digital transformation, and also technology projects more broadly. As Sabine said, we've met through a collaboration in terms of the University of Melbourne, and that all really flowed out of my academic experience, which sits alongside my more professional experience. So background for me is a master's in healthcare management, but more recently I studied for a master's in global public health through the COVID pandemic. And it was during studying for this master's, I became really passionate about digital health equity, as obviously we were studying through the pandemic and we were hearing more and more about inequities in terms of the experience about the pandemic across different communities, differences in terms of infection rates, deaths from COVID, and then consequently differences in vaccine take-up. And at the same time, we were experiencing this exponential growth in the digitization of healthcare in an effort to move very quickly to more virtual care models. So I wanted to really explore this as part of my research project, to think about whether this digitization was going to negatively impact certain sections of our communities. And since graduating, I've continued to continue my research. So we're doing some work with the University of Melbourne. And I've also become a peer reviewer for PLOS Digital Health and more recently Nature. So I review manuscripts in this space on digital health equity. Okay, I need to work out transitions. Brilliant. So I'm going to talk you through today my research and this realist review that I did. I'll talk you through the aims and the approach that I took. Then talk you through the digital health equity framework, and that was the output of the review and looks to synthesize all the barriers and all the evidence that I was finding across the research base, as well as looking at some of the influencing factors affecting equity. And then I will try and answer or give my thoughts on how we answer the question, how do we achieve greater digital health equity? If you've got questions, as Sabine and I chatted earlier, please do submit those questions. And Sabine, if you then see any particular questions, then feel free to stop me as I go through and see if I can answer. Otherwise, we can take questions at the end. So I'll start with some definitions. And I like this one. I use this definition by HIMSS in my research. Digital health technologies, what do we mean by that? This definition starts off by talking about technologies that connect and empower people and populations to manage their health and wellness. But it goes further and it talks about the need for technology to be augmented by accessible and supportive provider teams. And then also the ability to strategically leverage digital tools, technologies to transform care delivery. So essentially, to me, this speaks to the need for this partnership between the patient and their health team working collaboratively to deliver digitally innovative services. And then what's the definition of health inequities? And also what's the difference between inequalities? And the terms are often used interchangeably, but there is a difference. So when we consider inequalities, we're talking about the differences in the incidence, prevalence, or things like mortality or burden of disease that we might observe between different population groups. Whereas inequities, by comparison, are those differences that we might see, but are considered to have more of a moral, ethical dimension to them. And we might look at those differences and consider them to be either avoidable or unjust. And I really like this cartoon on the left that I came across because it really speaks to me about the differences between inequality and inequity in terms of how we respond to it. So if we think about inequality, we may then feel that we need to respond equally to some of the barriers in using technology, for an example. But if we're looking to address equity and deliver greater equity, what we might want to do is actually respond according to the barriers that are being faced. So we can then work and serve to level the playing field, which is needed across different populations. The word justice is increasingly being used, certainly within the research, and that talks about actually removing the obstacles that cause the barriers in the first place. Okay, so on to the realist review. And what is a realist review? How does it differ from a literature review? So fundamentally, it's based on the philosophy of realism. And realism proposes that an individual's external reality, so their real world experience, is perceived and interpreted through their senses, desires, language, and things like culture. And it's a theoretical approach through which we can explore more complex social interventions. And the idea is that we can then establish why they do or don't work in different contexts and what can we do to maximize our chances of success and minimize risk of failure. So the ultimate aim is through this realist review is to understand what it is about an intervention that works for whom, in what circumstances, in what respects, and why. It's increasingly used in healthcare because of this sort of health-related interventions that have a greater complexity and impact variability in different circumstances. And I felt this was a really good approach to start looking at digital health equity, again, for the different contexts and circumstances and the interactions between patients and users and their health systems and the technology in terms of the complexity of factors. But in practice, a realist review will start off with a much less defined structure when we compare it to more traditional literature reviews. So essentially, research is searched for and selected to answer specific questions or test particular theories in a more iterative process. In a more iterative process that and then enables patterns to emerge from the data. So the theoretical underpinning that I took was to underpin the research and to guide the search was a fusion of two theories. So on the left-hand side of the screen is an illustration depicting the social determinants of health, which was developed by the WHO's Commission on Social Determinants of Health to illustrate these pathways of causation of health inequities and how they then influence an individual's health and well-being. So essentially, we've got structural factors, so things like government policies, for example, and these factors flow through socioeconomic determinants, things like income, education, ethnicity, and through intermediate determinants, things like housing or in your environment, and that shapes the inequities in health that you experience across a population. Socio-technical theory to the right, that is really looking at the interrelatedness of social and technical factors and how they interact to influence actually use of technology. So on the one hand, we have technological factors, things like infrastructure, equipment, and applications. And on the other is the social system and the sort of the environment within which the technology is being used. There may also be external factors that influence this sort of joint optimization, which this theory says is actually what is required in order to support use. And some of these external factors might be things like training or implementation strategies. And I felt it was this combination of all of this factor that we had to actually use to frame how we're going to search and synthesize the evidence base. So more broadly, my research aim was to understand whether and how digital health influences health equity within and across populations and what we might require then from a policy and wider system perspective to mitigate these risks. So and ultimately wanted to understand what populations are affected by digital health equity, what barriers they experience that causes this inequity, and what's the mechanism through which an individual may be either unable in terms of skills or access to devices, but also being unwilling to engage with and use technology. So going really quickly across the approach, there's a lot of information here, but I'll start by pulling out some of the key points. So the first step is, and it's a feature of the realist reviews, to establish a panel of experts. And these are people that have real sort of deep knowledge and on-the-ground experience in digital health and health equity. And this is a key feature of realist review, because this panel then acts as a sounding board as you go through this more iterative evidence search process, so that what you search for and uncover in the research, they can help you make sense of what you're finding. They can work and discuss further lines of inquiry, but importantly, triangulate what you're finding from the research and triangulate that with their sort of on-the-ground experience. So that was a really key and valuable feature as I went through this process. Then you prepare for the search, and that means building the conceptual and theoretical framework, which I just showed you, and then the code structure. So you have to actually uncover the research and you have to tag it and code all the research that you're finding. And then go through the iterative evidence search, where you're actually adding to the codes based on what you're finding out. And you are going through these subsequent searches and analysis until you've reached the point of saturation. And that means you're no longer finding anything new from the research. And at that point, you can finish with your search. And then you move on to synthesize all of the analysis. And I then constructed a conceptual framework and started the narrative that I was going to use to describe and explain, and then finally develop some recommendations for practice and mitigations that I was finding based on the research. So in terms of results, and I'll just give you some headline charts here. This was really interesting for me because it showed really strongly the massive uptick. So this is the year of the publications. And it's important to say that I found about 200 pieces of research that I read through this review. The vast majority were published around the time of the pandemic and afterwards, in line with that exponential rise in the use of technology. In terms of technologies, research, obviously, I was looking more broadly across all different types of research. And again, we can see that telehealth, video, and virtual consultations was the majority of research was sort of fit into this category. You can see a lot of different categories of technology. Vulnerable populations, again, looking across, tagged the research as to the key population that was being explored within the research. Race, ethnicity, socioeconomic, digital literacy are things that came out really strongly. Things like educational attainment, disabilities less so. You can see all the factors there on the screen. And then looked also at the intervention aim. So what was the research actually aiming to look at and explore? So there was 4 different aspects here. So there was differences in digital use across different populations. So some of the research looking at things like, measuring the degree of inequity across different populations and technology use. There were other types of research that was looking more at the health outcomes as a result of putting technology into a population. So it could be things like, is there different access to services, digital versus non, or is there different condition awareness or control in terms of different populations? There was other researchers looking at informing a policy agenda. So the link, for example, between regulation, reimbursement, and equity. And then finally, there was a lot of research looking at mitigations and what is needed to address inequity, such as, the success of co-creation techniques or other community engagement activities. So moving on to the outputs in terms of across all of the research, what did I find out? So this is an illustration of the digital health equity framework, which was the output of the research. And it's a visualization that essentially draws insights from across all the different themes, across all of the evidence base. And essentially, I developed this to highlight the barriers and to sort of provide a more visual overview of the barriers that people face along what I call the pathway to technology adoption, as well as the use of technology to improve health. So that pathway is summarized by the bright orange pathway that flows through the middle of the framework. And I'm going to come on to each box in turn. So if we start with access technology, obviously an individual will need access technology to use digital health. However, that is not just access to devices. What came out really strongly in the research was the need for access to infrastructure, both in terms of internet access, but also having the right bandwidth and speeds. And a user needs to be able to pay and afford devices as well as access to the internet and data. The research showed that there was geographical differences that sat very strongly here in terms of infrastructure availability. Many rural communities will suffer from worse infrastructure or may have reduced internet connectivity, reliability, or speeds. Often this flows from a historical lack of investment within rural communities. And that's really important because many rural communities globally are often older and sicker and therefore probably have the most to gain from digital health within those communities. The age differences that came out quite strongly here as well. So if we think about the Ofcom reported UK population of, so 6% of the UK population that don't have access to the internet, and we home in then on different age bandings within that 6%, and look more detailed, say at the over 75s, we find that jumps then to nearly 30% of over 75s without access to the internet. There's also strong socioeconomic factors at play here, which is a big driver of disparities that we might find with internet access and affordability of devices. Data poverty is a big issue here with unaffordable broadband and mobile phone plans, which affect in the UK between 13 to 19 million people, are thought to experience some degree of digital poverty. Also important, and this came out quite strongly in the research, was around the risk to the quality of care that you might experience through digital means for those that are smartphone dependent. And that means people that access the internet solely through their smartphone. And Ofcom believe that in the UK, 17% of UK adults will only have access to the internet through their smartphone. So you can imagine if you're trying to access your care provider through a phone, through a digital consultation, the difference in the quality of the care interaction than if you were talking to them on your laptop. So real sort of coming out in the research in terms of the barriers that might face for certain people. So moving on, we need skills and capacity. A lot is talked about this concept of e-health literacy or digital health literacy, terms that are used interchangeably. And this is essentially a fusing of having the digital skills to use the underlying technology with the need to have health literacy, which is the ability to understand and interpret health information provided digitally. So in terms of the digital skills gap, throwing some more stats at you, about 16% of the UK adult population will lack basic digital skills to actually use technology and keep themselves safe online. Can be more apparent within the older population who may have lower technical skills or dexterity issues, or potentially a reduced ability to learn in line with sort of aging and cognitive decline. Health literacy is a big issue that impacts health systems globally. WHO did a survey looking across 17 European countries at the rates of poor health literacy and found that between 25 and 75% of people, depending on the country, will face health literacy challenges. In the UK, that's 43%. And that just isn't an issue just for digital health, but also for more broadly in terms of health outcomes. So poor health literacy is correlated quite strongly with people having worse health outcomes in terms of reduced treatment adherence. They may have more avoidable hospital admissions and overall reduced life expectancy. Those with lower socioeconomic status and lower educational attainment are likely to have lower digital health literacy. Ethnic minorities was also coming through the research really quite strongly, in particular those that experience language barriers and the barriers that then poses on the use of technology for people that don't have English as a first language. This is important because a lot of digital health information frequently exceeds recommended readability level and is usually far more complex than health information that you might provide sort of a patient information leaflet or in non-digital means. And many digital technologies are quite complex and not always designed with accessibility in mind, and this will serve as a barrier to some people. It's really important while we're talking about digital literacy in particular that it's not just patient population that may have barriers in using technology, but also our clinical teams. There's a lot of research that is coming out in terms of health provider skills gaps. And this will then pose a barrier in actually the delivery of digital health services because you haven't got necessarily the provider skills to and not only use the technology, but also this understanding of digital health equity so that they can support some of their patients in understanding technology and supporting them in that sort of transition to digital. And then the final sort of pillar of barriers is the psychological factors. So we can have a device and we may have the skills to use the technology, but the final barrier in terms of the psychological factors are those that prevent people from using technology. So as a user, I need to see the technology as useful, relevant. I need to trust it and I need to have the confidence to both use it and make use of it. So things like relevance. Do I look at the technology and see that it's relevant to me? So use of technology was particularly hampered, and there was a lot of evidence within the research that when a technology wasn't seen as culturally reflective of the intended population, that then made people less eager to use the technology. Motivation was another factor in terms of, does an individual look at the technology and perceive it as beneficial to them and adding value to their life? So if we're not motivated, we don't see the value of technology, we're going to be less likely to use it. A lack of confidence is also reported in the research. So this was not necessarily correlated with skills. So you may have a lack of confidence or a lack of understanding of how the technology works, or have some general fears around using technology, not necessarily relating to a lack of skills. So more sort of the psychological barriers within the actual use and fears around that. There could be things like trust issues. I don't trust the technology, or I have concerns around my data privacy. Trust came out really, really strongly in terms of the factor that was critical for digital health adoption. And a lack of trust was correlated with a hesitancy to engage technologically, particularly within marginalized or historically excluded groups. Things like past experiences of racism or stigma flowed into a mistrust of both the technology and the wider medical community. Trust in tech was correlated and intertwined with this trust in the broader health system. An example of this was differences observed in vaccine take-up that were thought to be as a result of different degrees of trust in the health system. And also there's an interesting piece of research that looked at how trusting somebody was with it, of their health system and correlated that with a greater chance of them downloading and using the COVID-19 app. People with disabilities or sensitive stigma-related conditions, things like HIV, STDs, these people were felt to be very vulnerable of inadvertent disclosures, and that then flowed into a hesitancy in using technology as well. And then the final part of the pathway, it was my attempt to recognize that actually using technology doesn't in of itself use health, but actually what we do as a result. So do we better adhere to our treatment? Do we implement lifestyle changes to improve our health, for example? So it's that behavior change in using the technology that I felt needed to be there to result in health equity. And then I'm going to move on to some of the influences that sit around that pathway to use. So firstly, we've got the political influences. And we've got things like government role in terms of shaping the environment within which digital technologies are deployed. And that directly influences access, safety, trust, and affordability. So things like directing infrastructure and investments into more underserved areas could be one example. Within the US, there's an example where the Biden administration established this Internet for All initiative. And what that did was allocate 65 billion to expand broadband access and to tackle what they call digital redlining. So this was the practice of infrastructure companies preferentially installing high-speed fiber broadband into more wealthier communities, which that was happening was then further marginalizing some of the more deprived communities. So this was directing investments directly into some of these more deprived communities. In addition, they also provided funding for low-income families to better afford internet contracts and data. A government may have reimbursement policies, such as in Germany, there's the Digital Health Act, which is a performance-based pricing mechanism for digital health technologies. And they may use regulation and having robust regulation, particularly around data security and data protection, was correlated with an improved willingness to use technology within healthcare. And finally, governments can adopt sort of policy frameworks or national action plans to drive greater equity and adopt things like international guidelines. For example, WHO's 6 AI principles is one way that governments may bring some of that international guidelines into practice within a country. So as I talked earlier about the social determinants of health, they're also obviously an influencing factor here, but I want to just home in on the term intersectionality and why that's important here. So essentially what that's saying is that we've got different factors that we're saying influence health. But actually, when we look at intersectionality, what we're doing is we're recognizing that many individuals won't just experience these factors separately, but actually a clustering of barriers. For example, think about an older adult living in a rural area. So they may face challenges not only related to aging and potentially challenges around digital skills, but they may also have more limited broadband infrastructure. They may have fewer healthcare options and potentially also experience social isolation. So they may not have the support to help them to use technology. So these intersecting barriers don't just add up, they compound and reinforce one another, making access to digital health even harder for some people. In addition, the use of some of these terminologies, things like the elderly or minority ethnic groups, things that terminology that may be convenient, but can often mask wide variations at an individual level in terms of their needs, preferences, and capacities. So one 75-year-old may be really tech savvy and digital active, but another may have never used a smartphone. So lumping people into single categories actually doesn't serve anybody really well when we're looking at designing solutions that can fit everybody. And then finally, within this, it's important to just stress that barriers aren't static. So if we think about what are the digital skills and confidence are within an individual, one day that may evolve over time, and that might be influenced by changes over the life course in terms of income, health, or support systems. Largely, this sort of considering the multifactorial and intersectional factors was largely missing from the research, and a lot of researchers are now talking about this need to actually think about more broadly these factors and how they interact with one another. And then finally, thinking about the health system as an influencing factor. And some things coming out really strongly in terms of the research, starting off with how inequitable is your care provision? Because if you're putting technology into an inequitable health system, you're more likely to drive inequities in terms of use of digital health across your population. Secondly, do health providers have the right infrastructure in terms of resources and technologies? Do the providers and the clinical teams have the skills and confidence to use technology? Does the provider and the health system use data to provide an awareness of who equity populations are, and then being able to monitor and evaluate penetration and use of technology across system? These were all things shown to influence whether a technology was being used. And then I'm going to try and answer this in terms of how do we achieve greater digital health equity. And I've developed this sort of four-stage process drawing from all the mitigations that were talked about across the breadth of the evidence base, and tried to simplify it, so putting it under four headings in terms of the stages of technology adoption. So starting to think about addressing the system influences way up sort of downstream before we even get to thinking about technology. Some of these system influences we need to address. So have we got the foundations right? Have we got formal governance in place for digital inclusion? Does the health system have the right organizational vision, strategies and policies relating to digital inclusion? Do they have the right funding budget in place for digital equity, as well as the roles in place and understanding and how to support the organization's equity agenda? I think I talked before about the need for the clinical teams to have the skills to support patients in the shift to digital. And can an organization support that through things like mentorship initiatives, training programs, and things like continuing education opportunities, so that you can start upskilling your staff, particularly in the use and the maturation of digital tools that you want them to use? Are you using data to understand your population risks in terms of digital exclusion? So do you know who's excluded, and also, excuse me, what might be the clinical impact of any digital exclusion? So an example of where this is being used really well is Greater Manchester Digital Exclusion Risk Index is one tool that's being used to highlight the risks of digital exclusion. So that's looking at data relating to demography, deprivation, and broadband, and bringing all of that data together to look at a geographical risk factor across a population. Because it's only through knowing what your risk factors are can you actually design the appropriate interventions and respond with things like action plans to improve literacy and digital skills within some of the communities. And we also need to work with communities to build trust, because without it, as I said earlier, we risk that technologies won't be adopted. And therefore, there's a need to create engagement with communities to understand what matters to them. And building on that, particularly when we move to stage 2 and preparing for technology, that's delving deeply within communities across different types of communities, different types of users, to understand the needs of the users in terms of their perspectives and the barriers that they may face, their social contexts, and building all of this into the digital requirements that you start building up for the technology that you want to put in. Or alternatively into some of your procurement decisions, knowing that not all technology is developed and designed, but actually we may be buying technology. There's a need to deliver this term digitally enabled equitable care. And what I mean by that is actually taking a step back, not just putting technology into a service, but actually redesigning our services to make best use of technology. and to ensure it's not presenting as a barrier to access. As part of that, we need to think about patients' preferences for digital or non-digital engagement so that we retain high quality in-person care for individuals that either choose not to or can't engage digitally. And I like the term that was talked in one piece of research called digital alongside care models, where we can have digital or non-digital services used interchangeably. And as part of that, and importantly, is care continuity, where the same clinician provides both digital and non-digital care. But ideally, we would then empower the clinical teams so that they could best support patients digitally and help them to transition. As I said earlier, this needs empowered clinicians with skills and confidence to do that. And then moving on to how we design technology, there is a number of strategies that were talked about in the research where we can center more around the human requirements of technology over the more technological strategies and requirements. So let's starting to think about universal design, and that's an approach that's being taken to design technology for the widest possible user base. So that's thinking about not necessarily needing adaptation or specialized design, but building things like accessibility functionality within a single design of a technology. But going further than just universally designing, it's thinking about more human-centered design approaches. And that means that we're now designing with communities, not for communities. And that requires co-creation to actively consider and accommodate the needs of very different user bases. But as well as getting feedback from communities throughout design, testing, as well as implementation, so that we can have more iterative evolution of technology, so that we're uncovering issues both in the design and in the implementation on how technology is being implemented, and being able to iteratively, evolve the technology as we go through that process, as well as evolve the implementation strategy. The concept of design for equity takes that one stage further, and that's more intentionally designing technology to be used for people that may have more sort of systemic inequities and barriers to using technology, so that we can be more intentional in considering the needs of more vulnerable users. And some examples talked about in different research is things like designing apps with more simplified user interfaces for users with limited tech experience. Or it could be things like more simplified languages or pictures even for users with low literacy. Or it could be things like the use of SMS as alternatives to more complex health applications. Moving forward in how we implement technology, that's more intentionally rolling out and deploying technology in ways that are far more inclusive. So some of the things that the research shows are strategies through the implementation are things like this ongoing community engagement to continuously build trust and skills within the patient population. It may be things like supporting peer support, where patients help and support each other through use of technology. It could be providing training, or actually, in some instances, providing device or data affordability support. There is this need to continuously collect data so that we're actually identifying gaps in penetration into certain communities, and therefore we can respond accordingly. So in other words, we need to monitor in those early days real world use so that we can identify really early on the barriers to use and be prepared to iterate and adapt the technology as well as the implementation approach so that we can continually evolve to meet the community's needs and barriers as they're being faced. So then one final slide that I wanted to give a little bit of a plug. As Equity Health, we've started to develop this maturity framework. And I'm looking for people that are really interested in learning more about this and can help support us to test and iterate this. So we've intended this as a self-assessment to bring together where we feel the key domains within the movement to greater digital health equity that an organisation needs to consider, so that they can self-assess and then monitor their progress towards greater digital health equity. So yeah, if you're interested in learning more about the framework, then please do get in touch. And that's everything that I've got to present. I'll just end with this slide, which is a quote that I came across in terms of my research, and this has really spoken to me. So I'm presenting it there for you to look at. So this is Jeff Wast in the Lancet Digital Health, who talks about any healthcare development that doesn't rapidly become available to all individuals has the intended but inevitable consequence of fueling health inequity. So that's everything. More than happy to take questions.